The National Center was established in 2002 as a resource center providing information, consultation, training, and TA to child welfare, dependency court, and substance abuse treatment professionals. The center is jointly funded by SAMHSA and the Administration for Children, Youth, and Families, and it grew out of an understanding of the very substantial role that substance use plays in child abuse and neglect cases. Last year, Steve Gumbley, the former New England ATTC director, began a partnership by reaching out to the National Center to facilitate building a regional collaborative in New England between substance abuse, child welfare, and the courts. And we're just really happy to partner with the New England ATTC to create a learning community to highlight the issues facing child welfare, substance use treatment providers, and the courts. Through the partnership, the National Center and the New England ATTC is launching a web-based series of presentations to highlight and disseminate information on effective practices in connecting child welfare, substance use treatment, and family courts in the 6 states that comprise the New England area. That would be Maine, Massachusetts, New Hampshire, Vermont, Rhode Island, and Connecticut. In the next slide, just to lay the groundwork for what we're going to be doing today, the kickoff webinar, you're going to hear about issues facing child welfare, substance treatment providers, and courts, and initiatives that were launched in the New England region to respond to these issues. Feedback from the regional survey will also be shared to highlight the challenges and opportunities of New England states. This feedback will be integrated to highlight potential priority areas for technical assistance provided by the National Center and the ATTC to assist jurisdictions with practice and policy changes. And very shortly, Dr. Nancy Young will provide more detail about the training and technical assistance resources available to you through the National Center. What I'd like to do now is introduce our partner, Dr. Sarah Becker, the Evaluation Director for the New England ATTC, who's going to provide the history and mission of the ATTC. Dr. Sarah Becker is the Evaluation Director of the New England Addiction Technology Transfer Center and oversees regional initiatives to support prevention, treatment, and recovery of youth affected by substance use disorders. She's an assistant professor at Brown University with a dual appointment in the Department of Behavioral and Social Services at the School of Public Health and the Department of Psychiatry and Human Behavior at the Warren Alpert Medical School. And currently she's a principal investigator of a 5-year early career award from the National Institute on Drug Abuse that studies ways to increase the utilization of evidence-based treatment models for adolescent substance use disorders. And so let me now introduce Dr. Becker.
Thank you so much, Sharon, and hello, everyone. On behalf of the New England Addiction Technology Transfer Center, I want to share how delighted our organization is to be partnering with the National Center to address such an important public health issue in the New England region. And for those of you to whom the ATTC may be unknown or unfamiliar, I wanted to share a bit about our history and current mission. The ATTC network was established by SAMHSA in 1993, and at that time it consisted of 11 addiction training centers that served 19 states and Puerto Rico. The network recently celebrated its 20th anniversary in 2013, and we're now a network of 14 regional offices and a national coordinating office that has expanded to serve all 50 states as well as the U.S. Virgin Islands and Pacific Islands. And a map depicting the coverage of the network is depicted on the left-hand side of your screen. The overarching goal of the ATTC network and of each of the specific regional offices is to improve the quality of prevention, treatment, and recovery support services offered to individuals affected by substance use disorders. This goal is met through a series of specific objectives which are outlined on your screen. The first is to raise awareness of evidence-based or promising prevention, treatment, and recovery approaches. The second is to help the workforce both in traditional addiction settings as well as in allied settings such as mental health, criminal justice, and child welfare to build the knowledge and skills needed to deliver state-of-the-art treatment and recovery services. The third is to change practice by helping frontline providers, administrators, and agencies to incorporate these new skills into their everyday use. And the fourth is to build alliances across systems of care and diverse stakeholders such as clinicians, researchers, policymakers, and funders. Given these goals, we're thrilled to be collaborating in this initiative that seeks to foster alliances across the substance use disorder treatment, child welfare, and court systems. I now have the privilege of turning it over to Dr. Nancy Young to provide a national perspective on some of the key issues affecting families in the child welfare system affected by substance use disorders. Dr. Young is the Director of Children and Family Futures, a California-based research and policy institute whose purpose is to improve outcomes for children and families affected by substance use disorders. She serves also as the director of the SAMHSA-funded National Center on Substance Abuse and Child Welfare, our co-sponsor today, which provides technical assistance to states in the support of their efforts to enhance cross-system collaboration for the benefits of affected families, and develops and disseminates information on advances in policy and practice in this field. Among her many other responsibilities, she also serves as the director of the federally funded Regional Partnership Grant Support Contract. So please join me in welcoming Dr. Nancy Young.
Thanks so much, Sarah, and thank you for all of the participants for joining us today. We're delighted to be able to partner with the Northeast Regional ATTC and to be able to share some resources that we hope will be helpful to you. I'm going to step back for just a minute, and you might say, oh, 1997, that was ages ago. What could be relevant at this point to that long period ago when the Adoption and Safe Families Act was signed into law? Many of you may be very familiar with that. If you're in the substance abuse treatment world, I hope that you're familiar, but it may not be as familiar to those that work in child welfare or in the courts. But landmark legislation in 1997 that required timelines for how long children can be in out-of-home care before having a permanent plan about who will be their primary caregiver and their primary relationship for permanency in their life. Around that same time, there was recognition that that requirement for a permanent plan in 12 months put increasing strain on child welfare agencies to ensure that families had the best opportunity in order to care for their children. And in fact, at that point, there were about 5 national reports that came out that in fact said very common things when they identified what were the barriers, what makes it so difficult to just work across lines between substance abuse treatment and child welfare and the courts and make things happen for families that they have an opportunity for treatment and recovery and to parent their children. And these 5 reports said some very common things. You see a link to where you can find the shorthand, if you will, to those 5 national reports. And I go back this far to that time period because I think many of these barriers are relevant still today. The differences in values and the perception of who is the primary client. We heard that many, many times. The substance abuse treatment agencies would say, but the parent, the mom, the dad, that's who we are charged with serving, and child welfare would say, but child safety is our paramount concern. And in reality, when we have groups that work together and we try and facilitate dialogue, the reality of the whole family as their client becomes obvious very clearly to them very quickly. We also heard a great deal about the new requirements in ASPA causing timing differences in the service systems, in particular the difference between that permanent plan that needed to be put in place as if a child was in out-of-home care, or that social services were to move forward with termination of parental rights if the child was out of home care or in out-of-home care for a certain period of time. Those timing differences sometimes were in conflict with treatment agencies that had a philosophical or a treatment plan approach that said that there was no contact with family or children for the first 30 days. And if this was an infant or a young child, how that posed conflict for child welfare to say They can't wait that period of time. They can't wait for the 6-month court review in order to show that they are making progress in their recovery. Also, profound knowledge gaps. Just some of those basics that I mentioned already about the differences that operate in the substance abuse treatment world and that operate in the child welfare world, that the knowledge gaps about each other's system were profound. And the time that it took sometimes for communities to come together and to help the other system understand how do they work, where does their funding come from, what are their mandates, what are their requirements, that those knowledge gaps needed to be filled, as well as the basics of substance abuse treatment, that there was an information gap for child welfare workers about, well, what happens when I send them over to that treatment agency? What does their assessment look like? What does treatment look like? What are the various levels of care? How do I understand what a treatment agency is recommending in terms of the modality or the time in treatment or the residential versus intensive outpatient? So some knowledge gaps that needed to be addressed. The fourth that was summarized in these reports is about that need for screening and assessment and ways to effectively engage families in this change process. It can be very threatening to have a case in child welfare, and that idea that now I'm going to open up and to say that I need treatment, what are those effective services? And the knowledge that has been gained in the substance abuse treatment field in terms of motivational interviewing and motivational enhancement therapy, and how do you move that individual or help them move from not understanding that they need to go through this change process to really facilitate that. So those effective engagement strategies that needed to be put in place. A gap in what was really needed for the children. We recognize that these kids are at very high risk of developing their own substance use disorder. We know that kids in out-of-home care, when they are adolescents, use at higher rates than their peers who have not been in foster care. And yet the gap in what needed to happen for prevention and intervention for substance abuse treatment or substance abuse prevention, as well as mental health services for the trauma that these children may have experienced, needed to be put in place. And how do you communicate all of that across these systems when you have various state laws and federal requirements about what is the right way to communicate, and how do you ensure that that communication happens in the best interest of the whole family, while safeguarding those protections that are so important for substance abuse treatment participants to have in their well-being. The data and information gaps, as we look at how many of these kids, and I'll get into that in just a moment, but that those information gaps continue in many states. And the good news is, and we'll talk about some of the initiatives that have happened in New England to address some of those data and information gaps, but we find that those are still relevant in many communities across the country. And then those issues, the thorny stuff of how do you possibly look at the treatment gap about who needs to be in treatment and how do you pay for that? How do you understand the funding streams that operate in substance abuse treatment, and how do you operate so that you can work with the funding streams in child welfare? So those 8 barriers, if you will, between the systems really called for a way in which collaborative practice could happen so that there was a joint approach to solve those barriers and for communities to come together. And in 1999, as a result of the Adoption and Safe Families Act, that asked the Department of Health and Human Services to provide a report to Congress on how to solve these barriers, how to identify the barriers, and what are the national goals about how to address those barriers between the systems. And HHS issued the report. If you haven't pulled that out in a long time, Blending Perspectives and Building Common Ground came out in 1999 and established these 5 national goals of establishing collaborative relationships, assuring timely access to comprehensive substance abuse treatment, improving the ability to engage and retain clients in care and to support their ongoing recovery, to enhance the children's services that were needed, and to fill information gaps. Sound familiar? Those barriers and the way in which HHS looked at those and crafted these national goals has been important as we look at the progress that has been made over the last 15 years to address those barriers. And in fact, one of those initiatives that Sharon spoke about, the creation of the National Center on Substance Abuse and Child Welfare, that was charged with both developing knowledge about how to do this and to provide technical assistance. And then in 2007, as Congress amended the Promoting Safe and Stable Families Act and provided funding to test some solutions. What could we do as a nation in various communities to better understand how to address those barriers? And the initial grantees, the 53 sites that were funded from 2007 to 2012, really had a lot of flexibility in the kinds of programs that they put in place, the ways in which the performance measures were crafted, so that they could really begin to experiment and to provide some evaluation about what works better with which population. And I'm delighted that in just a bit I'll be able to share some of those performance measures and their results. Then again, 2 new rounds that have been funded in regional partnership grants. You see 17 that are currently in operation and 4 that were just announced today. So I know that they are happy and at the same time challenged with some of the responsibility of really providing the information for the rest of the country about what kinds of partnerships, what kinds of initiatives, what kinds of practice and policy need to be put in place to address this critical set of families. And then in 2010, SAMHSA provided funding to 12 family drug courts, recognizing that these issues for children, the prevention and the intervention and the parenting needs for families that were known to child welfare, their parents were participating in family drug courts, and great information that has come from that round of grantees that implemented a range of child-focused interventions to, again, address the trauma that they experienced and to address the family needs of how to bring together children and families to recover together. So again, we're delighted that we've been able to look at some of those performance measures and to provide that information. It's important when we think about these particular initiatives to have a picture of how many kids are we talking about. Now, clearly not all kids who are living in a family in which substance use is a factor are known to the child welfare system. But these data come from the National Survey on Drug Use and Health, and they've been very consistent even before these data in 2002-2007 were released. The prior data were also very similar, with over 8 million children in the country that live with a parent who is alcoholic or needs treatment for illicit drug abuse. 8.3 million children, sometimes those numbers are just such that I can't really get my head around, well, what does that really mean? It means 11% of the kids in the country. it means that in a school classroom of 30, on average, 3 are going home to a family in which a parent is alcoholic or needs treatment for illicit drug abuse. When you think about the enormity of that number, 3 in a classroom, you begin to get the picture of the challenge for child welfare. On average, in the last 5 or 6 years, about 200,000 children have been placed in out-of-home care. 200,000 children that are placed in protective custody when you have 8.3 million that are living with a parent with a substance abuse problem. And I go through those numbers in a little bit of detail because I think it helps, again, to paint the picture of some of the challenges for child welfare to understand not just mom or dad is alcoholic or needs treatment, but what effect does that have on the abuse or neglect of that child? What role did the substance use play in what happened to that family? And what role does substance use play in the ability of that parent to safely take care of the child? When we think about those numbers and we understand that the majority, while not all of the kids are known to child welfare, of those that are known to child welfare, while there are various ways in which we try to count that, and we'll talk a little bit about those data gaps, in specific studies that have been conducted, we find this range of 60 to 80% of the families that come into child welfare are from families in which parents have a substance use disorder. And you see the 3 recent ones that are cited more frequently, and that range of prevalence. And yet, when we look at the data from the administrative data sets that are filed with Children's Bureau, we've highlighted the 6 states in New England. These are the percentage of cases, percentage of children who are coming into out-of-home care, and the administrative data set is checked off to say that parent alcohol or drug use has been a factor in the removal of that child for placement in protective custody. The national average of 30%, and you see the percentages that are in the New England states. Now you say, is that because New Hampshire just has so much less substance use? We don't think so. We think it probably is much more a factor of how those data are collected, the supervision of caseworkers about ensuring that that gets put into the administrative data set, those other gaps that we talk about, not just in the data collection systems, but also in the training and the understanding and the ability to do the screening that's necessary. You note that Maine has 46% and Connecticut at 33%. Again, do we think that they are more impacted by substance use disorders than the other colleagues that they have in New England? We think not. We think that that is probably a factor of the initiatives that they have put in place over the last several years for both training and understanding how to assess and to engage parents and how to record that in their data set. So we spend a little bit of time on the data again to ensure that we think about the successes that have gone on in New England, as well as the challenges that remain in terms of identifying families that need services. And you might say, but Nancy, you know, it's data, you know, so there's a lot of variation. But if I were a state policymaker in, say, New Hampshire, and you came to me and said, you know, we have this treatment gap. We really need more availability of funds for this population of children who are being placed in out-of-home care or are being identified with allegations of child abuse or neglect, and we need to have more treatment resources for their parents. The first thing I would ask is, well, how many are there? And if you can't say how many there are in a way that justifies a need for resources, I think that the policy implications for that might be clear. So it's a challenge not only for these issues of sustainability of programs and resources, but because of these data. These data are the number and the percent, the percent across that bottom axis. I'm sorry that those numbers are not showing right now, but you can see the percentages that, I'm going to try one thing. Okay. Sorry, the percentages aren't showing, but we'll fix that when it goes back out so that you see that. But the percentages of neglect are in the 70% range, and you see the New England states in orange and the national data in the blue. And what this says are the number and the percent of all children who had their parental rights terminated by reason of the removal. So you saw that range of reason for removal across the New England states, and yet it is the second most frequent occurring issue as to why parental rights were terminated. That's why, in part, data are important. That's why, in part, clinically, this component of termination of parental rights, perhaps the most important action that child welfare takes and that the child welfare courts, the family courts, institute in the life of a family. So if we're thinking about pictures in your head that I hope that you go away with, this graph is an important one because this is profound implications for the families that we're talking about in terms of having a substance use disorder that is affecting their ability to parent and their ability to reunify and to safely care for their children. We wanted to highlight some of the initiatives beyond the data that we just covered. Some of the initiatives that have been put in place, we mentioned the regional partnership grants, and these are the locations in the New England states that have operated regional partnership grants called RPGs, and a little bit of the efforts that they have put together in terms of ensuring the screening and the assessment and the engagement that has gone on in terms of addressing these barriers that we spoke about. So 4 sites in New England that have received funding from Children's Bureau for regional partnership grants. And then states that have worked with us at the National Center in our program of in-depth technical assistance, and a brief description of the kinds of interventions and the kinds of policies that they adopted. I mentioned previously that Maine had that higher percentage of identified substance use among parents. And you see that many years ago they actually adopted a screening tool as a universal screen for early identification of parent substance use in child welfare-involved families. You also see that in Massachusetts, they implemented a family engagement program to improve that early referral, engagement, and retention in substance abuse treatment and other services for child welfare-involved families. And then in Connecticut, what they refer to as the RSVP, the Recovery Specialist Voluntary Program, which are recovery specialists that have been trained to provide motivational interviewing for understanding substance use and how to ensure that from that assessment process that parents are engaged in substance abuse treatment with a statewide network that's available to child welfare workers to have assessments conducted and engagement services put in place. We also wanted to highlight that there are a number of family drug courts that are operating in the New England states. These are states that are drug courts, rather, that are identified through the National Association of Drug Court Professionals. And from these initiatives, but more broadly from those data that I mentioned from the regional partnership grants and the children affected by methamphetamine grants, when we looked at the performance measures across those two programs, and as you heard, 53 grantees in the RPGs and 12 grantees in the CAM, or children affected by methamphetamine, we were initially surprised and then obviously pleased to see very consistent kinds of changes in the performance measures for these set of families who participated in these programs. And we began to coin the 5 R's, meaning that parents had increased recovery, that there were an increased number of children who were able to remain at home without needing to be removed to protective custody, that there were higher rates of reunification, that there was less recidivism, meaning repeat maltreatment, and less reentry into out-of-home care. Substantial differences in repeat maltreatment and reentry into care, and consistent across those data sets. I'm going to share just a little bit about what we learned about improving those child and family outcomes. In particular, from the regional partnership grants, there was a big focus in the program strategies that they put in place in the way in which they looked at parent engagement and completion of treatment. I mentioned that in Massachusetts and in Connecticut that they had these programs that they provided substance abuse specialists, that individuals who were trained as substance abuse counselors, sometimes they were also paraprofessionals with peer experience, sometimes persons in recovery across these 53 grantees, that over all of them we found that the grantees accessed treatment quickly. Within 13 days of entering the regional partnership grant program, they were enrolled in treatment. Substantial differences between that and what we see in regular practice. That within 3 days, over a third of parents were in treatment. And they remained in treatment longer, a median of 4.8 months. And for those of you on the call today that are from substance abuse treatment, you recognize that the length of stay in treatment being so critical for long-term recovery, and that, in fact, in this group of interventions, that 2/3 stayed in treatment for more than 90 days, and a completion rate of just under half. Which if you're from the from the child welfare world, you might say, well, gee, completion rate of half, that is on average across the country better than what we find for the first episode of treatment for treatment completion. And I want to highlight that as we asked grantees what was important to achieve these kinds of performance measures, they really stressed that key supportive services, and that recovery specialist model, the way in which sometimes we heard it referred to, and for those of you that know CASAs, or child advocates that provide that that extra support to children, that these were in some ways CASA for parents, that they were the extra support that parents needed in order to navigate between that grief and loss and trauma that they had just experienced of losing custody of their child and making it across the system, if you will, into substance abuse treatment and to be engaged in those services. We also focused on, can we keep children safe when those kinds of services are being provided? And I mentioned the Remain at Home, with 92% of kids who were in the custody of their parent at the time of the enrollment, they remained at home during that entire period that their parent was participating in treatment. So these interventions reduced that trauma for children of separation for their parent. And in fact, when we looked from year 1 at 85% to the 96% in year 5, we know that that 85% is the percentage of children who remain or go home nationally out of child welfare. So of those kids who were at home at the time that the Regional Partnership Grant got involved with that family, in year 5, 96% of them were staying at home. And the repeat maltreatment that I mentioned, that almost 96% of children experienced no repeat maltreatment after the interventions were in place for substance abuse. And you see this table when we look at those kinds of safety and permanency outcomes that are important in the child welfare world. These are part of the measures that are a part of the Child and Family Service Review performance measures. So the percentage of children who had maltreatment within 6 months after the RPG program, same operational definition from the Child and Family Service Review, and you see a substantial decrease for those children whose parents were receiving Regional Partnership Grant services. You see the median length of stay, and from the child welfare perspective, you might say, well, gee, that's a longer length of stay in treatment. But if you think about that stability that happened in the life of that family, that's probably a good thing. Those services were extended for a longer period of time to really ensure that stability for the family, because when you look at that one that's circled and the substantial difference between those returned to care, re-entered foster care in less than 12 months. So a little bit longer on the length of stay in foster care, but substantial differences in re-entering care. And for those children who were not able to reunify, the second permanent plan of a finalized adoption being something that ensured the permanency for them. The common challenges, I believe now I am slated to turn things over to Sarah, so I apologize again for that change in my timing on that. And Sarah, let me have you speak about the challenges that you identified in New England.
Thank you so much, Nancy, and I'm delighted that you just took the time to go through that good news about some prior initiatives and accomplishments here in the New England region. I think those of us who work with families affected by substance use disorders don't always feel like we get a lot of good news, so it was really wonderful that you just went through that data about some of the initiatives that we've held here in this area. I now have the slightly more sombering task of sharing some of the key challenges that face our region as we move forward. And as I started to mention before, it was really important to those of us in the New England ATTC, as well as to our partners at the National Center, that we didn't want to simply share with you all what we view as the biggest challenges facing our region. Instead, we really wanted to make sure that we got feedback from administrators and from frontline staff across the child welfare court system and substance use treatment system to make sure that we understood from your perspective what the greatest needs were in terms of training and your ability to actually serve these families. So to that goal, we distributed a very brief and targeted survey. It consisted of only 5 questions, and we sent it to the single state agencies, or SSAs, in each state, as well as to child welfare commissioners and to contacts at the Family and Dependency Court. And we simply asked recipients to forward this survey to any other individuals they thought might have valuable feedback. Our goals were simply to get representation across all 6 states, as well as across multiple systems of care and professional roles. And what you see here on this slide are 3 of the questions that we asked, which were simply about people's background. And you can see that we actually met our goals, and overall we were really delighted with the feedback that we received. We did in fact get representation across all 6 states in the New England region. We had the most representation from Vermont, which comprised slightly more than half of our sample, and Rhode Island also comprised over a quarter of our sample. And then we received smaller but still very much appreciated feedback from the other 4 states within the region. When turning to the question about the area of primary responsibility, we gave people some options to choose from, and half of our respondents identified as being from the child welfare system. And then we also had some substantial representation of the substance use treatment system at about 20%. And then hovering closer to 10%, we had representation from the court/juvenile justice system and from the mental health treatment system. We had 1 respondent that identified as being focused on adolescent health more broadly, and that I believe was an ER physician. And then we had 2 individuals that just generally selected the other category, and in the verbatim comments said that they were involved with adolescent prevention, or with the prevention of parent substance use, but didn't really resonate with any of the options that we've given. We also asked people to identify their role within their organization, and perhaps reflecting our outreach strategy, where we started with a lot of administrators or leaders. About 40% or slightly under of our sample was comprised of administrators or executive leaders. We also had about a third that identified as managers or clinical supervisors. And we were also very pleased to have some substantial representation of frontline clinical staff and direct service providers. And then we had 1 individual that identified as a judicial officer or attorney. And then several people who didn't really feel like any of those roles really fit the description of what they did. And in the verbatim comments, most of those individuals identified as being planners, independent contractors, or affiliates of the government in some capacity. So moving to the next slide, we asked the question of respondents of what they viewed as the top 3 general day-to-day areas of training need facing their region. And we told respondents that they could select up to 3 responses from a list of 6 responses that we provided. And what we've done here is we've outlined the top 3 most frequently reported answers in the bars on the left, and then we've listed some of the other responses on the right-hand side. And we thought it was really interesting that we actually got some nice convergence around the 3 most commonly reported challenges facing these regions. And the number 1 issue endorsed by our respondents was the need for better collaboration across systems, and that was endorsed by over 2/3 of the population. Also, a very close second was more need for training focused on retention and engaging families in treatments. And then also another major issue is evidence-based interventions for families affected by substance use disorders. Some of these things may sound similar based on the challenges that Nancy brought up at the start of the slide about some of the challenges with collaboration and really keeping families in treatment for an appropriate duration. Other issues that people reported as affecting their region weren't reported quite as often, but still were reported by fairly substantial size of our respondent group. We had people, about a third of respondents say that they needed support with budgeting for or sustaining new initiatives. Also a third said substance use screening and assessment, and about a quarter said tracking and measuring family outcomes. 2 individuals took the time to write in some feedback, and the first said that they could use more support assessing the impact of parental substance use on children, and also support with budgeting and cross-training of different providers. And then the second wrote that all of the options were truly a major priority in the region. Moving on to the last question in the survey, we asked people also what they viewed as their top 3 special topic areas, or what we viewed as the hot topics of the day. So what were some key issues that were going on in their region that they really felt were timely and that needed to be addressed. And again, we gave people the opportunity to select up to 3 responses from a list that we provided. Once again, we had some nice convergence around the 3 most commonly selected answers, and very consistent with the feedback Nancy's been giving us. You might have heard her use the word trauma quite a bit when she's talked about the trauma that children experience, both in terms of living with a parent who struggles with alcohol or another drug use disorder, but also the trauma of being separated from the home. And reflecting these issues, a number of people said that they needed more training in trauma-informed approaches to care, with almost 71% of the sample. Another major issue that's probably not a surprise to anyone from the region on the call is the idea of more training in opioid abuse and medication-assisted treatment, which has gotten a lot of press in this region. And then another commonly reported issue was the need for more focus on transition age youth or youth about to age out of the system. Some of the other options that we gave people that were also reported by smaller percentages of the population were substance use exposed newborns, or substance exposed newborns was about 40%. Prescription drug abuse was reported by about 1/4 of the population. Minority and underserved populations was viewed as a training need by almost 18%. Parental custody rights, Medicaid and ACA implementation, and then the other category was endorsed by a handful of people, and the issues that emerged there were issues related to child safety, training and support for foster parents, specific training in CBT skills, diagnosis skills, and then specific screening and treatment approaches for adolescents. The last question in our survey, which we can see on the next slide, was an open-ended question where we just allowed people to share feedback with us about anything else that wasn't covered in the survey. And we've highlighted in bold here some of the things that really jumped out at us. And these are all of the verbatim feedback comments that we've received as of this morning. When I last peeked on, 2 other people had chimed in, and their feedback also overlapped with what's outlined here. Training was mentioned as a priority by 2 people. Another person wrote that there was a major issue with opioid abuse and that they needed training in safety and risk assessment. Adolescent marijuana and drug use was mentioned as being extremely high, specifically in Rhode Island. And then there was a desire for training in co-occurring disorders and a desire for training in parity rules or laws. And then someone kindly wrote that everything listed in the survey had been extremely important and was of great need in their state. So keeping this in mind, I'm going to turn it back over to Nancy to give us some good news about available resources within the region.
Great. Thank you very much, Sarah. We were, I guess in some ways, happy that the results came back in the way that they did. While these are all critical issues, we wanted to spotlight some of the resources and the tools of the National Center on Substance Abuse and Child Welfare that have already been developed that address many of the challenges that were identified from the survey. We organize at the National Center our resources in a framework of system linkages. And so many of those barriers that I discussed previously and the solutions that have been put in place, we categorize by these elements of system linkages. And rather than have me walk through that, I am going to ask Jonathan to launch a segment of a video that is available to you. It's on the National Center on Substance Abuse and Child Welfare's website, and it identifies these elements of system linkages, and the larger video goes through some depth of initiatives that were put in place in Miami-Dade County and Sacramento County to spotlight the way in which these elements come to life in practice.
At the National Center on Substance Abuse and Child Welfare, we've developed a framework for looking at the connections that need to happen between systems for families. We refer to this as the 10-element framework. It came about by the recognition that communities were often facing similar barriers and creating very similar solutions to those barriers. We took those barriers and solutions and organized them in a way that provides guidance to states, to tribes, and communities in the work of their collaborative efforts. When we say, go work with those other systems and create those partnerships, The framework provides a blueprint of how to do that and how to assess the effectiveness of those efforts. These key linkages are the bridges that are needed between the separate systems, and we've created some policy tools to facilitate building those bridges and ways to monitor their implementation. The elements are organized in 4 broad categories: mission and values, practice, the organizational changes needed to support the practice change, and monitoring the outcomes achieved. The framework allows a site to measure their progress using a tool called the Collaborative Capacity Instrument. It measures how they're doing in each of these areas of system linkages.
When we put that framework together of those 10 elements of system linkages and identified the barriers and the solutions that people were proposing, it became clear that over the last decade, many communities had come forward to say we need to do something different. We need to identify ways in which we can work together differently. And so a few years ago, we did a publication that's on the Children and Family Futures website called the Collaborative Practice Model. And that is a snippet, if you will, from communities that have addressed these system barriers and put in place the way in which they've addressed those 10 elements of system linkages. There's also a tool called the Matrix of Progress, which allows communities to identify where they are challenged and where they have made progress in their collaborative practice. 2 tools that we use very frequently at the beginning phases with communities and states when they're working on collaboration. The values inventory helps with that #1 system linkage that I spoke about, the collaborative practice and the principles about how these systems are going to work together. The collaborative capacity, or the collaborative values inventory, allows individuals to anonymously say, what do I believe? What do I think? What are my values about this set of families? And it provides an opportunity to have a voice across the system and to look then at those data in a way that allows communities to identify what they agree upon and what they're challenged by, where they're making progress, and where they have further work to be done is then identified in the capacity instrument. Again, an anonymous way for frontline workers, supervisors, administrators, across the systems and across communities to participate in a way that says, this is what I think is going well in my community. You know, we got that screening thing done. We're done with the screening and assessment process. I understand it. I understand how I'm supposed to access those resources. I know where I'm supposed to record it in our data system. That part of screening is going well. But you know what? The services to kids, I really don't understand what's going on to prevent these set of kids from developing their own substance use disorder. I need to really understand that better, or we need to do something better to address that. So the collaborative capacity instrument allows communities to rate themselves on how they're doing in each of those different areas of system linkages. Those tools are more fully explained on the resource page that you see identified on that website. I go through that in a little bit of depth because it also points to the way in which we have tried to identify the other tools and monographs that are available to you. So again, briefly, the values inventory, the CCI, because you have to have an acronym, the Collaborative Capacity Instrument, that allows you to rate your progress in those different areas. Then let's turn to that issue of training. We hear this frequently, that the training resources that are needed across the systems sometimes are not available. You are fortunate in New England to have a very active addiction technology transfer center. that allows substance abuse treatment agencies to participate in a whole host of training activities. At the National Center, we created some online tutorials. You see the 3 different tutorials that are listed. The first one is geared to child welfare workers, and it helps them understand substance abuse and their role in facilitating recovery on behalf of the parents that they're working with. The second is geared to substance abuse treatment professionals, and it helps them understand that complexity of child welfare and the dependency court. What's their role in understanding child safety? What's their role in providing information to the court about progress in treatment? How do you understand those various timelines of detention hearings and review hearings and permanency hearings and the different ways in which the court interacts on behalf of or with these families? And then the third, a guide to legal professionals, which helps them understand substance use disorders, treatment, and family recovery as they are interacting with families in their practice. So both attorneys that represent children, attorneys that represent parents, and those that represent either district attorneys or the social services departments. All 3 of these tutorials are available on the National Center website, right on our home page. And you see that banner in yellow, very important. Free CEUs. We find that in December we get an awful lot of people that are taking the courses because of the availability of 4 CEUs for child welfare and substance abuse treatment that are provided by the National Association of Social Workers and by NADAC, respectively, as well as continuing legal education units that are available for attorneys in the region. So we invite you to visit that website to explore those tutorials. In the nation, there are about 8 states that require all child welfare workers to take that online training so that they have access to that information on substance abuse and recovery. Overall, across these tutorials, there are over 50,000 people in the country who have taken these tutorials. So we're delighted with the reception that we've received from those. Let me turn to then some of the other resources. I'll explain them a little bit. You have the website where to find them. After the webinar, we'll be sending out the PowerPoint, so you'll have these links. And tomorrow, as we post this webinar to make that more broadly available to your colleagues, you'll have this so that you can get those links to follow up with any of these resources. In the first several months of the National Center on Substance Abuse and Child Welfare, the #1 call I think that we got was, give us the 6, maybe 4 questions that we can add to our investigation protocol that will identify that this family needs to be in treatment. And to be honest, sometimes it came from the perspective of we need to document our case in the investigation phase, and we need to understand what role substance abuse is playing in the life of this family. Well, we got that request very frequently, and we certainly understood that that was a much more complex question than 6 items that could be added to an investigator's protocol. And we spent some time consulting with professionals and bringing together experts to really understand what was needed in this area of screening and assessment in order to engage and retain families in this change process. So SAFER was born, Screening and Assessment for Family Engagement, Retention, and Recovery, that is available on our website. And the first section of that helps communities identify a way in which they can jointly develop those screening and assessment protocols and to ensure that the engagement and the retention that needs to be put in place for families is there. It also, at the back of the document, provides a whole host of an appendix that reviews the frequently used screening and assessment tools, both in substance abuse treatment as well as the risk and safety protocols that are often used in child welfare. So SAFER is an important resource. If you haven't looked at that already, I would invite you to do that. We mentioned some of the programs that are in place to provide what we refer to as substance abuse specialists in child welfare and dependency court. One of the first kinds of initiatives that we recognized were the outstationing of substance abuse counselors in child welfare agencies. In fact, New Hampshire is one of the earliest states that did that under a waiver of the requirements for funding under 4E to provide a substance abuse assessor in their child welfare offices. And subsequent to that, we've seen this in many, many jurisdictions across the country now, that it's one of the things that's recognized as a real needed resource by families. And so several years ago, we tried to understand some of the practice and the policy considerations that need to be put in place when you outstation a child welfare counselor in a child welfare agency or in the court. So this monograph goes through these 6 states that put those in place and identifies sort of our reports on their experience and their lessons about putting that kind of resource into the child welfare or court offices. And then another big question that we would get frequently is, and how do you put drug testing in place? We recognize that some jurisdictions spend a lot of their child welfare resources on drug testing for families, for parents in their caseload. And we looked at ways in which drug testing, the practice might be improved. There's a case study from a county in California that changed the way that they did drug testing, and in fact, Connecticut has modeled some of the way in which they changed their drug testing protocol from this monograph and the case study from the California county that put a different way of drug testing in place. So if you haven't had a chance to look at that and you'd like to think about the resources that you're using for drug testing and how they might be utilized in a way that really focuses on this need to engage families in this change process, I would invite you to look at that monograph on drug testing. One of the challenges that was identified in the ATCC survey was the components about how to respond to substance-exposed infants. And again, we identified some states that had put together some initiatives about this in particular, and that is provided in the state responses to the problem monograph. It covers the kinds of initiatives that need to be in place at the various points in time in which an expectant mother might be interacting with the medical system and then the child welfare system as the baby is born. So again, another resource that provides some examples from around the country about how to deal with this issue of substance-exposed infants. A little out of order, but there's the cover of SAFER, Screening and Assessment for Family Engagement, Retention, and Recovery, so you can identify that when you get to our website. It's one of the most downloaded resources that we have on our website. In particular, let me just back up and say, in particular, what folks download a lot is one of the appendices that lays out the communication strategy between the systems. So you've made the referral to substance abuse treatment. They've done their assessment. What is it that needs to get communicated back to child welfare? What is it that they need to know in order to write plans or to write reports to the court? What's the frequency of that? How that gets communicated? So one of the appendices in STAFER lays out a model with some suggestions about who needs to know what and when they need to know it. How do you reduce the noise between the systems so that there's communication at those critical points in time in which engagement of families is so important, as well as documenting for the judge and for the attorneys that are overseeing that case so that good communication is happening about progress in treatment and, importantly, what that factor is in terms of making decisions regarding the safety and the permanency for the child. Then let me turn back to the issues of prenatal substance exposure and highlight a webinar that we did just last week that highlighted an initiative in Burlington, Vermont, in particular, the Children in Recovery Mothers Collaborative. We were delighted to have individuals from Burlington participate with us on that webinar to talk about medication-assisted treatment for families affected by substance use disorders, in particular the opioid issues that are affecting the New England region, and what the CHARM Collaborative has put in place over the last decade to identify and to facilitate recovery and treatment options for pregnant women. I think one of the key things that I took away from the conversations with the individuals in Burlington is that their initiative has tried to reduce the surprises at birth, that they understand what's going on with this particular mom-to-be. They facilitate her ability to be participating in treatment. They recognize before birth the kinds of safety plans that need to be in place for the baby, and decrease the number of crises that are reported at the birth event by having a plan in place before the baby is born that addresses the safety concerns that may be in place and ensures the ability for moms and for dads to parent and to bond with their child whenever possible, and keeping that child's safety in the forefront. So again, if you weren't able to participate in the webinar last week, it's now posted on our website, and more information about resources that will be available through the National Center on Medication-Assisted Treatment will be forthcoming. We wanted to highlight, while this is not a resource of the National Center, to respond to that challenge that was identified in the survey, in particular around trauma-informed care, that a treatment improvement protocol from SAMHSA has been released recently, that if you aren't familiar with this, we would encourage you to look at that treatment improvement protocol. And you'll see when you visit our website many other resources that are available on trauma in particular, as we address the trauma experience for parents who are in substance abuse treatment and those that are identified in the Child Welfare Agency, as well as the trauma experience for children and the kinds of resources that are available to address that critical need for kids. With that sort of walkthrough of some of the National Center resources, let me turn things back over to Sarah to talk about the transition age youth work that is underway in New England. Sarah?
Hi. Yes, hi again. Another thing that came up in the survey as one of the top 3 areas of greatest training need in the special topic area was dealing with transition age youth. And so we thought that we would highlight some of the wonderful work happening here in New England already by the 6 states. And so we went to each state's department and pulled out some of the resources that the states have proactively put together to distribute to youth that are about to age out of the system and to their caregivers. And as we mentioned before, these slides will be available after the talk, and there are links here if you'd like to download some of these informative resources designed for the individual states to give you an overview of some of the resources that are available to you. And then moving forward, the last thing we wanted to talk about today is this webinar series going forward. And as we mentioned in the introduction, this is really the first in a series of educational events that we'll be hosting. And we're planning at least 2 more, and those are designed to reflect, again, the feedback that we gathered in our planning survey. One issue that was highlighted as being important was screening and assessment and ways to increase family engagement and retention in their treatment and in their recovery services. And so that's our next topic area. We'll be talking about screening and assessment strategies and also strategies to more effectively engage families. And then the final webinar that we're planning to do, webinar number 3, depicted on the next slide, is really focused on addressing this issue of trauma-informed systems assessment and approaches to care. The dates of these webinars are yet to be determined, but we're planning most likely to do about 1 every other month or so. And after today's webinar, you'll be getting an exit survey, and we really want to hear from you to make certain that these webinars moving forward are most effective. So related to these broad topics that we've outlined, if there are specific speakers you think would be valuable or specific topics you'd like us to address, please let us know. And we'd also love to hear from you if you think it might be worthwhile to do more than 3 webinars. We started with webinars because web-based trainings are very easily accessible to people, but we're also very open. And so if there were interest in doing an in-person forum or meeting and bringing people together to talk about some of these issues in a more structured meeting in person, we are also open to that feedback and would consider doing that as well. So please give us your feedback in the exit survey and let us know how we can shape this educational series to really meet your needs and your interests. And so with that, I believe that we have just about 10 minutes left for question and answers, which will be moderated by Nancy.
Thanks, Sarah. We didn't get many questions, but one that I did want to respond to is someone asked how could they get technical assistance through the National Center. Again, if you visit our website, there is a link to ask questions and just a little bit about what our technical assistance looks like. Beyond the series of webinars that you'll find on our resources page, there is a way that you can send in requests for basic information. We look at each of those TA requests and respond to each one of them. Some basic information, you'll get answers right away. We also can take requests for other kinds of, we need some research on a particular question that our staff can conduct. I don't mean whole research projects, but if you need to have some information on what is the latest research on the prevalence of substance use disorders in child welfare? What's the research on medication-assisted treatment or the way in which we need to address medication-assisted treatment? Or if you were on the West Coast, I would have used methamphetamine. What's the kinds of resources for methamphetamine? In addition to these monographs that I highlighted today, there are several others that are available to you and ways in which we try and respond to those informational kinds of requests. We mentioned the program of in-depth technical assistance that several states in your region have participated in order to really develop a longer-term strategic plan about dealing with these cross-system barriers and providing solutions in their state. we can provide technical assistance that's beyond just that quick, what's the information that you have available. So there's a wide variety of opportunities to ask us questions and to ask us for help across substance abuse, child welfare, the courts, and the related agencies that you work with. Again, I would invite you to visit our website. On the front page, while we weren't able to show the video today during the webinar, it's about 30 minutes, and I think explains really nicely the way in which the system linkages can help communities to identify their challenges and to overcome those challenges with initiatives. And it's always nice to have information from some communities that have actually put that in place, and to hear from judges and attorneys and substance abuse counselors and child welfare workers about what that change in their community has meant to them and the way in which they conduct their practice. We actually didn't have other questions that came up. Another question that just came in. Can you identify that for us, Melissa? Somebody asked specifically in the New York City metro area. I can follow up with that with some contact information from some folks who worked with us some years ago from New York, and some of the substance abuse specialist models that they had operating in Manhattan, as well as family drug courts that are operating in New York City itself. I'd be happy to follow up with some information about that. I believe that's the only other questions. We did get a comment from someone in California saying this may be New England, but it's relevant in California, and we agree. And if we can be helpful to any of the other individuals that participated from across the country, we'd be happy to hear from you. With that, I will close this particular webinar, and thank you again for your participation. We look forward to the next two in this series with you, and to hearing from you with how the National Center or the Addiction Technology Transfer Center can be helpful to you. Thanks very much, and have a nice afternoon.